Hello, my name is Christopher DiMaio, and I am the Director of Therapeutic Endoscopy at the Mount Sinai Hospital and the Icahn School of Medicine at Mount Sinai in New York City. Today I will be discussing the results of our study entitled Pancreatic Cyst Fluid Concentration of High Mobility Group A2 Protein Acts as a Differential Biomarker of Dysplasia in Intraductal Papillary Mucinous Neoplasms. This study was a collaborative effort between investigators at Mount Sinai and the Memorial Sloan Kettering Cancer Center. And on behalf of all the co-authors, we would like to thank the editorial board of gastrointestinal endoscopy for accepting our manuscript and affording us the opportunity to discuss our work. The diagnosis and management of pancreatic cystic lesions remains a common challenge for gastroenterologists. Of all the variety of pancreatic cysts, branch duct IPMN are the most common cystic lesion encountered in clinical practice. These cysts are of great interest as these are neoplastic lesions which can exhibit the full spectrum of cellular atypia, from low-grade dysplasia and moderate dysplasia all the way to high-grade dysplasia or invasive cancer. Given this risk, the identification of IPMN remains an important opportunity to identify patients at increased risk for pancreatic cancer and thus to potentially intervene before the development of malignancy. Current diagnostic evaluation and characterization of IPMN typically relies on the chemical, cytological, and molecular analysis of cyst fluid obtained at the time of FNA. Unfortunately, these current applications are wholly insufficient in detecting the presence of malignancy. As such, many patients undergo resection of benign or low-risk cystic lesions. But an easily measurable pancreatic cyst fluid biomarker of high-grade dysplasia or cancer could be critical in identifying those patients who would benefit most from surgical resection. Patients with the surgically resected IPMN and corresponding banked cyst fluid were identified for this study. IPMN were classified as either low-risk lesions or high-risk lesions. Low-risk IPMN were classified as those with low-grade dysplasia or moderate dysplasia, whereas high-risk IPMN were classified as those exhibiting high-grade dysplasia or cancer. Pancreatic cyst fluid concentration of HMG-A2 was measured via a commercially available ELISA. Samples from 31 patients were analyzed. HMG-A2 protein was detected in the cyst fluid of 30 out of 31 specimens. The median cyst fluid HMG-A2 protein concentration was as follows: low-grade dysplasia, 0.6 nanograms per ml. Moderate dysplasia, 1.55 nanograms per ml. High-grade dysplasia, 4.2 nanograms per ml. No HMG-A2 protein was detected in the fluid in the one sample with invasive cancer. Overall, the median HMG-A2 protein concentration was significantly higher in the high-grade dysplasia group compared to the low-risk group. There are a number of strengths and limitations to our study. The most important strength is that all cyst fluid investigations were based on lesions with corresponding surgically resected IPMN specimens. The main limitations of this study pertain to the relatively small sample size and suboptimal distribution of dysplasia subtypes. For example, the study population had only one specimen with invasive cancer, which was negative for the HMG-A2 biomarker. It was noted that fluid obtained from this lesion at the time of EUS-FNA was too viscous for standard CEA analysis, and this is the most likely reason that the HMG-A2 protein analysis led to a presumably false negative result. Nevertheless, a proper biomarker of dysplasia is only as good as its ability to detect cancer. Future investigation should focus on prospective collection of specimens with a larger sample size to allow for a better distribution of pathologic subtypes, in particular IPMN with invasive cancer. In addition, there should be a focus on the analysis of cyst fluid obtained at the time of EUS-FNA, as in this current study, most specimens were obtained at time of surgical resection. Lastly, the cyst fluid analysis results should be correlated with specific patient demographics, as well as radiologic and endoscopic findings, including the presence of high-risk or worrisome features, such as large cyst size, presence of intramural nodules, and the presence of main duct dilation. In conclusion, our study demonstrates that HMG-A2 protein is present and detectable in the cyst fluid of IPMN. Significantly higher concentrations of cyst fluid HMG-A2 proteins are found in IPMNs with high-grade dysplasia as compared to lesions with low-grade or moderate dysplasia. Cyst fluid concentration of HMG-A2 protein may thus potentially serve as a biomarker to differentiate high-risk IPMN lesions from low-risk lesions, and thus may assist in the preoperative risk stratification of patients who could benefit from surgical resection. We thank you for your interest in this study and invite you to read the manuscript in full for a more detailed analysis and discussion. Thank you.